Accrediting Nurse Associations of America. This continuing nursing education activity was approved for 1.75 contact hours by the Maryland Nurses Association and accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Following the webinar, each registered participant will be emailed a link directing them to an online quiz and evaluation. In order to receive your certificate of completion, you must attend this webinar in its entirety and complete the online quiz and evaluation you receive via email. You must earn at least a 70% on the quiz to receive your CEUs. Please ensure all contact information you enter is correct, as this is where we will email all certificates. We ask that all online quizzes and evaluations are completed by Wednesday, August 5th, 2015. Our faculty, Sharon Litwin, has disclosed no conflict of interest. Sharon Litwin is a founder and senior managing partner of 5 Star Consultants, a national consulting, education, and coding firm specializing in home care services since 2003. Sharon has been in the home care and hospice industry for over 30 years. She was also an ACHC surveyor until December 2013 and a former CHAP surveyor performing Medicare-deemed surveys for almost 10 years. In her consulting firm, she assists agencies in providing quality, meeting regulations, managing efficiently, and achieving financial viability. Sharon and her staff perform coding and OASIS reviews, clinical record reviews, do mock surveys, and help agencies across the country stay in compliance. Sharon regularly speaks at national and state associations and does frequent webinars for education firms on many topics integral to being successful in the home care and hospice industry. Sharon, please go ahead.
Heather?
Yes, are you there, Sharon?
Yes.
You can go ahead.
Okay, great. Well, welcome everyone, and thank you for joining us for our part 1 of the ICD10 series. As you can well imagine, I have been teaching ICD10 a lot, and so we, started probably well over a year ago and really never stopped. And it is so important that you're on now, because although it is now last minute and Dualcoding is already in place, it's so important to be sure that you have all of your ducks in a row, because this major transition is occurring so fast. It's amazing that we're already doing Dualcoding. I do want to tell you first off is that my allergies are really bad today, so please just bear with me if I have to cough or get a drink of water. Okay, so we're going to, in this session, cover a lot of topics, and it's mostly, overview and planning, why we're going to ICD-10. Some of this, without knowing what your group is like, it's hard to know how much you know and how much you've done already. But we'll just hit so many different topics, and I'm sure that you will get some good tips. How does ICD-9 different from ICD-10? Oh my, big. It's a huge difference. I just got done coding a hospice client just right before our call, and hospices take a lot of codes these days. It used to be just one code. Now it's everything that they have. And so I actually coded 23 codes on this patient and then had to dual code it in ICD-10. And it's radically different as you're looking up codes and doing that. So a lot for everyone to learn. What are your biggest challenges seen for implementation? And I break that down into 3 main categories. How can your agency plan, and of course, what are your training needs yet at this point? It's great that you're on this. So many people that aren't getting the training, I run into people in agencies a lot who just think it isn't a big deal, and I'm just afraid that after it starts, they will feel differently. Okay, so why? Why are we doing this? Well, it really is necessary. It's not just another thing that the government's making us do. The rest of the world is basically on ICD-10 and has been for a long time. Now, of course, I'm talking about the developed world, not the third world countries. And so, you know, for sure, we have to be in line with what other people are doing. Well, why are they doing it? Well, ICD-9 is limited. It doesn't say a lot about a patient's conditions, about hospital inpatient procedures, and it's 30 years old. Now, you know how much medicine has changed in 30 years. So it does have a lot of outdated terms, obsolete diagnoses even that are in there. And for some reason, the way ICD-9 is set up, they couldn't add codes to it. I'm not sure why, because if it's in a system, you would think that you could add them, but it could just be that the system is too old. Very much specificity in ICD-10, way, way more than in ICD-9. For those of you that code, you know a lot of codes in ICD-9 are not real specific. I mean, we certainly have those that are. But ICD-10, I mean, you may have one code for something in ICD-9, and that equates to 10 codes in ICD-10. When we're talking about pressure ulcers, as an example, that equates to lots more codes. So, you know, that's one of the things that makes this difficult, is because it's not one-to-one. ICD-10, they have built in lots of room for adding new diagnoses, how it's going to be upgraded for technology, for the performance-based payment systems, which we're entering into now as well, and more accurate billing. Because of all that, with the billing, making it more efficient, streamlined, then the government has more precise methods for detecting fraud. Okay, so again, ICD-10 is flexible for adding new codes, very specific. Just one example is laterality. I just coded a skin tear, basically, superficial wound to an arm. Well, first of all, I would have needed to know in ICD-9 if it was upper or lower, but then I had to go back and communicate with the nurse to say, I need to know which arm it is, because she didn't document that. Well, she should have been documenting that always, but now I wouldn't even be able to code it, because of course I'm not going to put unspecified arm. That's just one simple example, but laterality is pretty much in every code that you will put on, where it would be more than one. And so, of course, the coding accuracy is much improved because of this specificity. Okay. So they are completely different. You know, ICD-9 codes are almost all numeric. We do have our V&E codes, of course, and has 3 to 5 digits. Well, you know, one of the things that makes, especially initially, ICD-10 look so scary is because it's alphanumeric and contains 3 to 7 characters. And so it's very much different, much longer codes, and starting off with alpha, as you'll see. And I told you that because there's one-to-many matches instead of one-to-one, that is why there's not an easy crosswalk to use. Now, I am going to show you a crosswalk I made, and, well, some of it I had gotten from lots of sources, and others I've added to it. However, you always have to know that with crosswalks, you can't just put that in there. It is a guide, because there may be more than that one code. And you'll see why right now. We have 14,315 ICD-9 codes. That sounds like a lot, but we are almost at 70,000 codes in ICD-10. It is really amazing. I just recently took the ICD-10 certification test, and it is a lot more to look up in the book, as you can well imagine. I typically use the online coding center, which does make it a little easier for those of you that have that. But you know, they have put 69,099 codes into our coding book, so it's just a lot to look up. Also, of course, the books have changed, the styles have changed. There are 21 chapters, and I'll give you that chart too that has what they all are. And it includes every letter of the alphabet except Z. I'm sorry, except U. U is being saved by WHO for additional diagnoses. WHO, World Health Organization. They're really behind this. You need to know much more A&P, Anatomy and Physiology, than you did in ICD-9. And so that's one thing that if you do particularly have non-clinicians doing your coding, you need to ensure that they do have recent and sufficient A&P training and education. Now look at this. Surgical procedures. I thought 3,800 was a lot in ICD-9 for us, and I was so ecstatic when CMS said home care and hospice do not have to code those anymore, because we did not get the detail that we would need for that. Even if it's a total hip, you just don't know how the physician did it, etc. Well, now going up to almost 72,000 codes. Wow, I can't imagine. Thank goodness we don't have to do that. So the 7th character is very, very important for us because that tells everyone what setting the patient is in when this was coded. So we will never use initial encounters with A. Initial encounters are reserved for, the acute care hospitals and sometimes the SNFs, etc. We use subsequent encounters with D and sequela with F a lot. Sequela pretty much equals late effect. So when you think of a late effect CVA today, which we say and have so often, now it will be a sequela of a CVA. The D subsequent encounter means they're being taken care of in home care for whatever this is. So when you see 7th characters of A, D, or S, you do know a little bit about where the patient's been and what's going on with them. There are changes in time frames. The most dramatic is an acute MI. The time period for calling it acute has now gone from 8 to 4 weeks. Just a few years back, it went from 12 to 8. Now it's 8 to 4. So once you pass that, you would put old MI. So you have to look at some diagnoses where time frames have changed. Injuries are now grouped by anatomical site. So I think that there is 6 of one, half a dozen of the other, which is easier. So it's just a big difference. Here's just a chart to show you the differences. The second one down is first character is numeric or alpha in ICD-9, and like I said, it's only alpha for E or V, and it's only the first character. Now ICD-10, the first character is always alpha with all letters of the alphabet except U. In ICD-9, characters 2 to 5 are numeric, and in ICD-10, character 2 is numeric, but then character 3 to 7 are alpha or numeric. ICD-9, we have no placeholders. In ICD-10, there are. So for instance, where you'll find us using placeholders the most, which you put an X for a dummy placeholder, it means it doesn't mean anything, is if it's going to be a 7-digit code, that's what's told to you in the rules, then the 7th digit is for, let's say, a D for subsequent encounter, which is home care. Maybe there's no other codes for the 5th and 6th digit, and that's where we would be putting X's. So that does get a little confusing at first. In ICD-9, alpha characters are case sensitive, and in 10 they are not. Okay, so what do I see as your biggest challenges for ICD-10? I definitely think the three categories that I think are going to be and are starting to be the biggest problems are a knowledge deficit, IT systems, and specific information on referrals. Those, to me, are the biggest challenges that you need to work on, and particularly because we're last minute now. So if you haven't already, you will want to focus on these areas, and we'll talk about a lot about this during the class today. If you don't have a transition team or somebody who is leading the team, a project coordinator, it's not too late to start, because the whole thing is you should have a dedicated person responsible for making sure that the transition is smooth, and whatever is not gets recognized now and not next year. So again, if you don't have a plan in place, you want to put a timeline. Now, your timeline is going to be very short now, but make it like an action plan. Make it like a plan of correction, where your timeline would say, what is the task? Who is the task owner? What resources do you need? And what are the estimated start and end dates? Maybe you're just kind of scattered right now and you have been preparing, but if that's the case now, sit down and put everything down on paper in an action plan type of report with these answers, because maybe you started it 6 months ago, but gosh, you're really stuck, and now you need to assign someone else, you need to get more resources, and put an end date. And don't be afraid if the end date goes past October 1, depending on what the category is. You know, they're not giving home care any grace period on inaccurate codes as they are the physicians. The physicians, once again, cut a break, but we will have our claims RTP'd, returned to provider, or denied if they're not appropriate codes. So, of course, that's one of the first things that you have to make sure would go on your timeline, and what are all the steps to ensure that? Well, basically, the steps are these three categories. The training is do your coders know this well enough? Is your IT system working? And did you get the specific information, or are you coding very vague, inaccurate codes? Be sure that the communication is very good, both up and down. Leadership needs to be very involved, and pretty much everyone in your agency has to be involved. Well, it's a little late to budget, but if you haven't budgeted, you may have to work with your CFO on how to get the funds to be making sure everything is in place. You may need a lot more staff training. Maybe after today you say, oh my, I have to send 2 people to a 2-day seminar, or I have to order these modules so that they can really learn this. Maybe you realize that you do have some process changes in your office for workflow. Risk mitigation, we'll talk about that. If you don't have funds for that, oh boy, you better have that for your rainy day funds, so that if something goes wrong, particularly with slow cash flow because of slow productivity. And if you haven't talked to your payers, if you outsource billing, with your billing and IT staff, and a lot with your software system vendor about their preparation, about their readiness, you need to do that. So, your electronic medical records, your software system, they all have been testing. They all have had to, submit information on their tests. How are they going to be ready by the compliance date? Well, in essence, if you have a computer system that today cannot do dual coding, they're not ready, because now I have in here some agencies are starting. Most of the country, the agencies are starting August 3rd for home care to do dual coding. Hospice has already started. That's why I had to just put in all those dual codes. And I believe that date was July 3rd. And that's because of their 90-day first cert period. these episodes cross over the October 1 date, and so that is why the dual coding is pretty much necessary now, because they will be on your final claim. And if you don't code it at the beginning, dual coding, what are you going to do? If I'm your coder, you're going to have to give it back to me to now put ICD-10 codes at the final claim. So I know some of our coding clients, I have said, you know, gosh, you know, how come we're not starting dual coding with you? And they don't want to, and that's fine, but then they're going to have to come up with a mechanism to have the ICD-10 codes put in for the final claim. So is your software system ready? Now, when I say they recommend dual coding for at least 2 weeks as a test, that was prior to August 3rd. So hopefully you have tested it to see how your vendor has it set up. I know that there are some vendors that have not had it set up yet. And the one client that we have, their vendor is saying that it will be ready August 3rd. So unfortunately, some out there have not had it ready in advance. Okay, so I always skip way ahead of my slides, especially when I've taught a class so many times. Your clearinghouses, I did say your payers and your billing services, but don't forget your clearinghouses. You just need to make sure that every person, company, third party that touches ICD-9 codes you're getting with, because you have to make sure they're ready for ICD-10. If you haven't, you want to talk to your contacts at your vendors, your EMR, because you want to make sure that they are ready. Now, some of the systems have very good internet sites where, you know, you can log on with your account numbers and get a lot of training, a lot of information, see their testing, have the, you know, outline of how the dual coding works in that system. There are some systems where it's very easy, where when you put an ICD-9 code in to search, the ICD-10 codes come up next to that. Now keep in mind I said ICD-10 codes because maybe I put 4280 for CHF as an ICD-9, but probably your software system will have not just I50.9, which is CHF unspecified, but hopefully all the specific types of heart failure. If not, that would be an example that you don't want to just automatically code what pops up as the I50.9, whether you're looking at a crosswalk or in your system, because what we want to do is put the specific type of heart failure. We don't want to put CHF unspecified. We want to put all of the exact. So there are many CHF codes that are specific now in ICD-10. And that's where then you go back to, you want to have the referral information say the specific. The one thing about us getting specific information from discharge summaries, from HMPs, from reports given, other notes given, a lot of home care agencies have said, we're just not going to get this specific information. It ain't going to happen. But keep in mind, the physicians have to do this too. And so the hospitals are working with the physicians. The SNFs are working with the physician. Outpatients working with the physicians. All to the doctor's offices are, because they have to have this documentation specific. And so because it's everybody, it's not like something like face-to-face where, here we go, the docs don't want to be bothered with home care again and with this face-to-face. And so that's why we have such a challenge with that. Well, ICD-10, for once, it's not just home care. It's the whole healthcare industry. You have to, as you're working through everything, have someone, the project leader, and then hopefully working with your CFO and your administrators and your CEO, you want to try to avoid any potential reimbursement issues, interruptions to workflow, all of that creating terrible cash flow problems. And so that is why you ensuring that your system vendors are ready is so important. Make sure if you need any system upgrades or replacements, whether it's hardware or software, that you're doing that now. What training, what upgrades are covered by existing contracts? Well, you need to know that, because I know some of the systems, there are fees involved as they're doing this. Others is just a regular upgrade. What training will they provide? Like I said, a lot is online by the vendors, but we are signed up, me and the coders that are on 2 of our clients. Those 2 separate software systems are having training events, webinars, that we are also signed up for. So it's important, if you are outsourcing your coding like this, you know, for instance, these clients let me know that there are these training sessions being given and invited us to attend. So make sure you're involving your outsourced coding company, because it's not always easy for an outsourced coding company that's not an agency to get all the specific training that comes up, or be able to log on to the agency site. So you have to help them with that. And you have to make sure that they're ready for this dual coding. How are they going to separate this? How are your claims going to be dropped? What's going to be on both of them? Make sure that that is set up and tested by them, and asked to see this, because it's crucial that October 1 on, there's no ICD-9 codes on the claims. All those that transition over are ICD-10. Just don't get caught off guard with your software system. You know, way back, if any of you, you know, when I have in there, Heather said, I've been in this industry over 30 years. All that tells you is how old I am. But gosh, it seems like, I mean, I've been in home care and hospice industry since I think I was 23, so it's a long time. Anyhow, when we went to PPS, for those of you that remember that, there were some big systems out there that couldn't do it. They couldn't do the claims for PPS. And one system in particular, one big software system, and also keep in mind, back then there weren't as many software systems. There were probably less than 10, where now there's, gosh, 100. They could not get their agency's claims billed, and those agencies didn't receive any Medicare money for probably 6 months after PPS started. So you know that there's going to be some software vendors that are going to have a real challenge with this. So just make sure that it's not your system. Don't get caught off guard. CMS ICD10 websites have a lot of information, and they do have vendor information. So how can you increase your knowledge other than what I'm telling you? They have the timelines with the checklists for the IT vendors, and they do have it for what small, medium, and larger organizations. So where you fit in, you'll be able to see and pull up that information. So you go ICD-10 websites, and then under provider resources. There's a lot of different sites there for us. There are the GEMs on the website. Now, the GEMs are generalized equivalency mappings. Of course, they can never call it something simple like Crosswalk. So the GEMs are many, 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 many pages. It has locked up my computer several times when I've gone into that over this past year. It's not a crosswalk. CMS says it's not a crosswalk, and the reason, you should probably know this by now, is that there are many more diagnoses in 10. So you might have an incorrect code or a lesser paying code if you only use the GEMS or my crosswalk or any other crosswalks. These are not intended for dual coding. They're not, CMS even says the GEMS is not intended for learning or practice. So, you know, that's a caution against GEMS. They're also pretty complex. So I haven't seen a lot of agencies using those. Where the ICD-10 website is cms.gov/ICD10. You'll see latest news there. In fact, I need to go sign on again because they've had some recent updates that I know about through the email. Provider resources, payer and vendor resources, and then the GEMS. Those are the main categories. All right, so training. I hope that this is not your first training. If it is, don't panic. You still can definitely have time to learn because learning is going to be ongoing. It's certainly not stopping at October 1st. There are going to be so many seminars and webinars continued to be provided because this is complicated. And until you really start using it, you won't realize that. My partner and I are in the office this morning, and I have 3 calls and 4 emails this morning that came in to say, can you please send me information on your outsourced coding because we're going to be going with that, and can you please call us to let us know about how this works. 7 in one morning, and that's because people are so busy. There's so many regulations. There's so many changes in home care and hospice that an administrator and the rest of the administrators' teams in the agencies have a hard time just taking care of the patients. And now, ICD-10 is here. So it's not too late, and keep in mind that you're going to continue to need training. AHIMA, American Health Information Management Association, has really done a lot of piloting and studying on training. And, they even said, and this is another thing, that don't panic if you haven't done a lot till now, because more than 6 to 9 months prior to October 1st is really tough because you are working with dual systems, and because all the very specific details that I studied and studied and studied for the test, for the certification, how much can my brain actually contain if I'm not doing it every day? Now, training needs, of course, vary dramatically. What AHIMA predicted from their pilots, now, they did not do home care, but they had outpatient coders, and they said 16 hours and 50 hours for inpatient coders. We are more on the scale of inpatient coder, even though sometimes we're considered an outpatient service because our codes are so complex of what is required. So I just know from being a coder, from having coders work for me, and then all of our consulting clients that we don't code for, working with their coders and their directors to have training. 16 hours is not sufficient for this. So I really feel that it is upwards of 50 hours. If you haven't already, you need to purchase publications and hopefully resources as well. Now, the ICD-10 coding books you can pre-order now, and you have been able to pre-order for about 3 months. They are supposed to be shipped mid-August is what I heard recently. Originally, they were saying September, which goodness. And like I said, we're already doing dual coding. But how you take your certification test and how you do your dual coding and train is from the preliminary editions of ICD-10 books, which have been out for about 2 years because those came out way before last year when it was delayed. And so if you don't have that, it's a little late in the game to get that. However, if you don't have anything for dual coding, you almost have to get that. And then the interactive websites, I'm really personally a proponent of it because I feel like it increases productivity so dramatically. Now, I do have a few coders who say, no, 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 I'm in love with the book. I will never, ever, ever give up the book. But this year when we bought the Coding Center just recently, I had about a dozen takers and probably 4 already on it. So that really means probably only about 6 of our RN coders are saying, no, I don't want it, I'll keep the book. And it really has become so sophisticated. The only one I know about is the Decision Health Coding Center, but I know that there are others out there. Now, keep in mind, and I'm not a proponent for any type of coding book or Decision Health. It's just the coding center that I use and that my company uses to help us code without looking at the book. When I say interactive, I do not mean Googling all your diagnoses. The other day, a nurse put in a unapproved, by the way, abbreviation in her documentation about a diagnosis, and I didn't know what it was. And it is difficult in our coding book and in the coding center. It's like a dictionary. If you don't know what the word is, it's tough to look up, right? Well, in this case, I thought, well, let me just code the initials that she uses. Let me just put the initials that she uses into Google and see if anything happens. And I'll be darned if it didn't come up. And so Google is amazing. And again, I'm not promoting Google. I should say Yahoo or Bing or whatever. But they really can help at times like that. But those are not to be used as your coding. So when I'm saying interactive online coding, I don't mean Google. And then there are a lot of publications. Again, the only reason I'm saying another Decision Health publication is because I have that. It's attached with the Coding Center. I like that because that gives me all the updated changes, the information, education, CEUs, etc. There are other coding magazines out there by other coding companies. I just don't know them. There are a lot of quiz books for ICD-10 scenarios. So even though we're so close to the date, I always recommend getting these because what better way to practice than to have a scenario and then have to code it in ICD-9 and have to code it in ICD-10. Pretty soon, you'll just need to code it in ICD-10. But that, to me, has been one of the best ways for agencies to really get their staff up to par. And quite honestly, as a coding company, not only my coders, but I've had my consultants do this as well for well over a year. We're giving out the scenarios and having them work the scenarios. So you can see all of the things you have to do to get prepared. I talked about how you have to individualize the training for each person, but somebody who is non-clinician and is very involved in ICD-10 needs to have A&P classes or buy, webinars or training modules. And so that's how you're going to see what responsibilities everyone has in your agency to what training that they need. Don't wait to find out that your coders aren't ready. If either they don't have the skill set or they haven't had the resources and training, and then they are doing their best, but they are putting wrong codes in, that's going to affect your financial viability incredibly. So that has to be something that you need to address now. Whether to outsource or not, this is not me talking as an outsourced coding company. We, 5-Star Consultants, we've been in business since 2003, and we've been a full-service consulting firm since then. We started our coding division about 6 years ago. One, because I found that I really liked to code, and so that's why I started this division. And two, because our clients needed it so much. And from that, it's just grown and grown. So I'm not, this is not a conflict of interest because what I'm doing is giving you the facts. When you look at whether you outsource coding or not, well, what do you want to do? You want to make sure that you look at the pros and cons of each. And so that's what we're going to look at later in this series to really help you identify the pros and cons. But when you're looking at your clinical and your intake and your clerical staff, you really want to ensure that, yes, we have the people that can have that skill set with training and resources, and we are good to go with lots more training or lots more practice. ICD-10, the conventions and the guidelines are very different than ICD-9, so you have to learn them. If anyone is getting certified, which of course if you do in-house coding, your coders, I very much recommend that they should be certified. It ain't easy, let me tell you, it's a tough test. And I was trying to find out from the BMSC, Board of Medical Specialty Coding, that is the organization over our coding certifications, what the first-time fail rate is across the country. Now, they do have the pass rate very low at 74, which is surprising, but I think that's because they know that if they didn't do that, people would really be struggling and having to retake it frequently. You're almost done with when you can take it so that you don't have to take the full test. If you are ICD-9 certified today and you take it by July 30th, you have the person's test that is for a certified person, which is 50 questions. If you wait till August 1st or past, you have to take the full test, which would mean a non-certified person comes in new and takes it. And I believe that's 85 questions. So if you are pretty ready to take the test, if you've been studying a lot and you're pretty ready to take the test, you would want to try really hard to take it before July 30th so that you don't have to take 35 more questions. And like I said, don't stop your training because ICD-10 finally starts. Ongoing practice has to occur, and those practice scenarios are so valuable that you do as a group and then go over, or you assign as homework, whatever, but they're very helpful. I'm sorry, I jumped ahead of my slides again. You know, when you are preparing for your ICD-10 cert, I didn't go to any on-site seminars, but that's because I've been teaching it for so long. I've been studying it for so long. I have bought lots of webinars, lots of module classes for my training. A lot of my staff have gone to on-site seminars. If you're fairly new to ICD-10 and want that structure, you can go to those 2-day seminars and take the test on the 3rd day. You don't have to take the test, so if you just want that information, you can go to that as well. But don't think, because I know ICD-9 coding, I've been certified for a long time, and I have flipped through the book and taken Sharon's webinar, that I can go and do the test. It's difficult because there are so many different rules, conventions, and guess what? There are 69,000 codes. All right. So your referral intake information, like I have said, much more information is needed to code in ICD-10, and most cannot be coded by what the clinician states. There are only a few exceptions. There are new codes to measure the severity of non-pressure ulcers, and those, I believe the L89, it just popped out of my head, but codes are there to say, is that non-pressure ulcer only at skin breakdown level, at fat breakdown level, at necrosis, bone, and that can be a clinician saying that from the assessment. The BMI, there are a few others, but and then of course we always have a lot of symptom codes yet if we have nothing more definitive. We're going to get into that a lot more next session, part 2, when we get into specific coding. But as things pop up during this session, of course, I want to let you know. So, in other words, you have to have this in writing. If you're one of these agencies that just doesn't get a lot of information on referral, you're going to have to change that way, that policy, that process, because I do have clients, both consulting clients and coding clients, that don't get information, that we are basically coding from what the clinician puts in. Well, when we do that, we're saying, you have to query the physician to confirm these diagnoses because we don't have that documentation. So, of course, the clinician should not just be getting this information from the patient. They need to have it from the physician, if it's from a physician's office, from the hospital, from the subacute setting, and a lot of information. Now, I will say I've been really pleased with probably 25% of our clients have not gotten good information, and over this past year, they're getting better and better information. So that's what you need to do if you have a problem with that. Now, let's say maybe you have 90%, 95% of your referral sources are fine. That's what often happens. But maybe you're sitting there in the room going, I will never get this information from Dr. Jones. Well, that's when you have to go pay Dr. Jones's office a visit and really talk about this. And how you can talk about it is saying that Dr. Jones has to document all this in his record as well. So if he is one of the physicians that just gives very non-specific information, that has to change on his side too, and then you just have to ensure that you get it. You want to always try to get the face-to-face complete at the referral. And so if that patient has been in to see the physician in the past 90 days for that same primary reason as home care, you should be able to get that. And that's so important because we do want to make it flow from the face-to-face. Agencies that get face-to-face very, very late, it's a problem because then they're 485, they're OASIS. A lot of times it's looking at different things than what a physician puts on the face-to-face, where you could take care of that if it was early. What you want to do is make your own crosswalk. This is really easy because what you want to do is look at your most frequently coded conditions. That is the best crosswalk of all because you're going to say, here's my top 20, and here are all the codes that go with those top 20. And so your crosswalk can be very specific to your needs. And that's real important because obviously there are going to want to be, or your coders are going to want to be able to memorize some of these. Do you know that there was an estimate I read somewhere, and I have no idea if this is scientific or somebody throwing a number out, but they said that somebody who's done coding for a long time has an estimated 2,500 memorized or near memorized codes in their head. And gosh, I believe that's so. I can talk in diagnoses codes. And guess what? Those all have to be thrown out and new ones started. And probably with all the teaching, with all the studying I have done, I probably only have 10 to 15 memorized. And so that shows how complex it is. Unfortunately, our brain isn't like a computer where we can purge it and say, okay, archive, and then delete, and then recycle bin all of those ICD-9 codes. They're there. So unfortunately, they're taking up a lot of room in my brain, and that's why I can't find my keys ever. Okay, so I talked about dual coding. Very important. You really have time yet to say we're going to start dual coding on August 3rd. If you're hospice and haven't started it, you're a little late, but hey, start it as soon as you can to this day. If your coders are ready, if your software system is ready, if your clinicians have been trained in what they have to document and you're getting that referral information, then you're ready. But let's say you're not quite there yet. Well, maybe you can still dual code, or maybe you need to wait. And then that would be, like I said, a problem upon final claim if those cross over past October 1. All right. Your productivity and staffing. Well, AHIMA said that you could see a 40 to 60% decrease in coding productivity. 50% decrease in productivity was demonstrated during the August HIMSS WEDI, I always forget what that is, ICD10 National Pilot Program. So I don't know if any of you have been in that, but 50% decrease in productivity. Now, this was the pilot that was just for hospital and ambulatory care, sorry, so that wasn't for us. But I feel that absolutely it's the same for home health, particularly since we have a harder time getting information. The HEMA certified ICD-10 trainers who were in this pilot program, they had significant error rates at only 63% average coding accuracy. That's terrible. And they had a 50% drop in productivity. Now, can you imagine the impact on home care agencies with a 50% drop in productivity, and that's only a 63% coding accuracy? Now, that's why me, as a coding, who owns a coding and consulting company, but particularly talking about the coding side, I have been, over this past year, hiring, I've been training, I've been not letting up on any of my coding staff on training, getting certified, getting the online coding center, because obviously we can't have that drop in productivity, because how would we be able to have a quick turnaround for our clients? But now you, as an agency, all of our consulting clients that I'm working with, and my consultants are working with on this, if you have that type of productivity, you're just going to come to a screeching halt. You don't have the staff. Your cash flow will just be nil. And if you only have a 63% coding accuracy, you're going to have a lot of RTPs and denials. So this is why training is so important. Now, even if you've done the maximum training for the last year that you know you have to do and everybody is really up to par, you want to have a backup plan. So now what is being projected is that you have up to 6 months worth of cash reserves on hand, or have other financing resources so that you can, I'm sorry, this flipped out of slide mode, I bumped that, so that you can be protected. And that's something that definitely your CEO and CFO have to be involved in. Okay, so I talked about this before. If you're looking at whether to outsource or not, some of the advantages is obviously the cost and time for training your own staff. The second one, you hope that you have experts reviewing and coding, and that will result in less error. You should, if you outsource to any coding company, and there are so many out there, you expect to see experts and less errors. You only pay for your volume. So if your productivity decreases, you're not going to have to pay the overtime. And also, you won't get things done. So, of course, your cash flow and your compliance for being so late will not be as affected as much. And this is where I said they have a time frame. When you have a coding contract, you're going to tell them what time frame. Typical, it's 48 hours or 2 business days. And so maybe if you keep it in your office, it will take 7 days. And so that's one of the advantages. The demand for coders, and I can see this because of all the coders I've hired in the last year, is expected to increase 18% over the next 3 years overall in healthcare. So obviously you're going to have much more difficult time hiring qualified people for your agency because you have your local pool of expert coders that everybody's vying for, where not all the coding companies, there are coding companies that have their coders come in to work at their site, so they would have that same challenge. But the coding companies that work nationally remotely are able to pull experts from the country. So you do want to look at that when you're evaluating coding companies. Now, what are some of the disadvantages of outsourcing? Well, you have to be careful. There are, like with anything that happens in this country or maybe this world, when new things come up that are possibly revenue making or a good business, guess what? Lots and lots of companies pop up. And that's what's happening with coding companies. So just be sure that you have a quality agency. You want to assess if you want to use one of the many coding companies that use clerical coders versus clinicians. With the ICD-10 being so complex and with the knowledge of OASIS and tying that all together, if you want to have coders that are really reviewing OASIS, your H&P, your narratives, your meds, your orders, you might want to say, well, I want clinicians versus clerical coders. So that is especially since I'm outsourcing. So that's something you have to evaluate. And, you know, I've seen several email advertisements over this past year from several companies that, you know, are thought to be big and reputable, but you have to be careful when you talk to them because they were saying that their coders can do 20 to 25 assessments a day. I have to tell you, when we are really bogged down and our coders are doing 15 a day, that's not good. That ends up with human error very often. It is complex. It takes a long time to go through all of the documentation and to code. Now, maybe their coders are just given a list of diagnoses and they can pop them in. So again, it depends what you're looking for, but you definitely want to take a look at that. Keep in mind, too, that, you know, your coding company might be short-staffed also. Hopefully your coding company isn't letting you suffer with the time frame that you get back your assessments, but if they become super short-staffed, that may be a problem. So you probably, and again, this was written, you know, at the beginning of the year where I say you want to outsource sooner than later, and you heard from me today, just 7 calls this morning about it. So now I think a lot of companies are saying, oh, we better do this now. We better start researching various coding companies. Make sure when you are set up with a coding company that they collaborate with your staff. Remember, the clinician who does the OASIS is the assessing clinician and is in charge of everything that goes in that code and goes in that OASIS. And so when you have a coding company, be sure that there is collaboration to the assessing clinician, that they are agreeing with, that they are looking at what the coder put in the codes and then in the OASIS, and they are querying the physician as needed. They are giving the coder more information, and they are the ones saying, yes, this is good. All right. Don't slow your process down if you outsource. If you don't intend to take processes away when you outsource, then I recommend you don't outsource. What I mean by that is there are actually some of our consulting clients, they would say, okay, we want you to do our coding too. And we would then see that what they were doing when they got it back from us is they would have their director, you know, patient services or QI or whoever, review the whole OASIS, review all of the coding and the referral information before doing the 485. Well, if you're not going to take away a lot of those lengthy processes, then I would recommend don't outsource. All right, now you can see this timeline. Obviously, you are adjusting the dates. The reason why I am not adjusting the dates to current is because maybe you have done some of this. So maybe your timeline has much of this information on it, and what you're going to be doing is just updating those dates and making sure that everything is occurring that needs to be occurred. So sorry, I'm not sure why this is flipping. Okay, I'm Maybe it's where I have my mouse. And so, you know, when you look at what should have been occurring, and definitely if it hasn't, you would want to start now, and this is to help you build your action plan in writing with your timeline for ICD-10, what staff need what type of training. Don't waste a lot of training time on staff that aren't going to be touching the ICD-10 codes, but maybe they're in your referral intake department, or maybe they are. The one person is your referral intake department. A lot of managed care require codes before the clinician even goes out. Plus, your referral intake person is going to be saying, ooh, I need more information from you, referral source. Remember the AMP for clerical staff. If you haven't started that for clerical coders, you want to get that now. And like I said, you don't have to go on site for that. There's many training books and webinars out there. General education on the fundamentals of code application. That's what you're doing now. And so if your whole staff isn't in there, you want to then present this to your whole staff so that everybody knows what's happening. This is a big change in healthcare. Identify your commonly used diagnosis, and this is kind of different than what I said about making your own crosswalk. This is to identify the commonly used diagnosis so that you know what requires more documentation. Obviously, anything with laterality, much more detailed information on wounds, and pretty much every other diagnosis you can think of. However, what do you have that's special to you that you're going to have more documentation for? And your processes. Look at your processes. What has to happen to make you more efficient in these areas, if anything? It's always a good time. You know, I go into agencies so often to do an assessment of them, and often in addition to looking at compliance, they have us looking at process efficiencies and operational efficiencies. And when we come in, you know, with that objective third eye that's hard for you and your agency, so often you can see processes that really haven't been updated in a long time and now can change because of the EMR, because of different referral sources, etc. And you want to really take this opportunity to look at your processes like that and say, oh, we could streamline here and make this more efficient. Maybe that will help with your decrease in productivity that's going to hit you. Again, you really want to do your referral sources one by one on what documentation requirements you have. Obviously, start with your problem children, and you know, I'm asked this at the end of almost every single session that I do, whether it's on site or a webinar. In the Q&A, people will say, what happens if we just can't get that information from Dr. Jones? It's doctor's office referrals, and it's the old assess for home care. Excuse me, I have 25 more minutes. I better not lose my voice, but I don't know how allergies are this year where you are located at, but my goodness, they're bad here. At Lake of the Ozarks, Missouri, lots of trees, lots of pollens, but also I travel constantly. And everywhere I go, no matter where I am in the country, I hear that allergies are terrible this year. So, okay, so your field clinicians, how much do they need to code? Well, they need to have knowledge of ICD-10 diagnosis coding because of the specific diagnoses, because of the differences that are in the rules for diagnoses, because of some of the big dramatic changes with wounds, because of what they're doing in the home. They're the assessing clinician, and then as they go forward. Now, if they're not the assessing clinician and they are another discipline or other parts of the team, let's say an LPN who's going to go, or LVN, depending on where you are, going in on later visits, they have to know what those diagnoses are. That has to flow through the episode of care. That's a weakness that I see in chart reviews a lot now, and I was a surveyor for 10 years. I left being a surveyor a year ago just simply because of how busy I am and how much I travel already. But I found that a lot as a weakness and really help my consulting clients with when we do chart reviews, because the OASIS and the 485 will say one thing, but then as you look at the visit notes through the episode of care, what they're putting as their primary reason for home care is different, and that has to flow. So this is a great opportunity to in-service and train all of your clinicians to say this and to say how this has to flow, and therefore the changes in the codes. All right. Yeah, coders cannot get too much training. Let me tell you from experience. You should give the coders scenarios weekly and really look at them to see how they're doing. Of course, we talked about the outsourcing. So, you know, now as the rubber's starting to hit the road, continue training. What does that mean? That means dual coding, which isn't just training anymore, but it is good practice. For me and my coders, like when I just had to put in, there's a very expensive, well-known, reputable system, software system, that their dual coding doubles the time, because you truly have to enter the codes for ICD-9 and then enter the codes for ICD-10. And so it just takes time, double the time, just because you're doing the same thing twice. But I was talking to one of my coders a little bit ago, and we both had hospice clients that had a lot of codes that then we had to put in twice, doubling our time. But then afterwards we were laughing about it and saying, my goodness, this practice is wonderful. We're learning so much from it. So you have to look at the dual coding that's necessary for transition for final claims as practice as well. Be sure, this is something that we have found before with our consulting clients, is that they have maybe someone teaching and in-servicing. Maybe it's your education coordinator, your QI coordinator, depending on the size of your agency. Maybe it's your supervisor, your administrator. They've had a few classes like this, like I'm giving you, which is just an overview. And even next week when we talk about the nitty-gritty coding, that's in 90 minutes. I mean, I've had probably 150 hours of nitty-gritty coding. You have to make sure that who's teaching it is experienced and is that expert. The problem, if they're not, is that little bit of knowledge. You may lead everyone astray because of the complexities of ICD-10. The conventions, which are like the absolute rule in ICD-10, have changed a lot. The guidelines have changed super a lot. How do you like that? All right, we talked about that. So, competencies, you have to make sure you're doing competencies, particularly on your coders. You have to expect productivity losses. So if the CFO or CEO are not listening to me today, which I doubt that they are, you need to talk to them about that. You need to project that even at this late date, because you don't want to be shocked. Be sure that who's doing your coding system, you don't think this is so easy because they just pick what the coding, you know, if you have one of the, like I said, that one I was just talking about, you have to do it completely over. But there are a lot that the ICD-10 codes pop up once you put it in. If it's a one-to-one, be sure they just don't pick one. What will happen is you may, for instance, I-50.9 CHF unspecified, that's probably not a case mix code where all of the other 20 are, probably are. And so you will also, in addition to having incorrect codes, you're going to get less reimbursement if you take the easy way out and put unspecified. Now, this is a really important consideration. You need to audit the first, I would say, 3 to 6 months of your coding to make sure you're compliant and to make sure you're not putting wrong codes in. Make sure you're getting the best reimbursement that's accurate to this patient. That audit is going to be so critical because you need to make sure before it's too late that you don't have a big issue. All right. Well, ICD-10 is now creating OASIS C1 to change to the ICD-10 version. Remember, we went on OASIS C1 ICD-9 version January 1st, and that was because CMS was not going to stop rolling that out when the legislation passed to delay ICD-10. Mostly what is changed in this OASIS version is just the coding categories, and so it's not a big deal to teach that and learn that again. But that will start on October 1st. So again, if you are on paper, you have to order those forms. If you are on a computer system, you have to make sure that your software vendor is ready for OASIS C1 ICD-10 to start October 1st. All right. Your start of episode date indicates what you use ICD-9 or ICD-10 on the wrap. Your MO09 date determines your type of OASIS. All right, some general coding differences just to end on. We don't have a lot of time, so as you know, this is going to be very brief. Injuries, like I said, are grouped by anatomical source. So you would specifically look those up by, you know, the extremity, the head. Post-op complications are moved to a different chapter, a separate chapter, mostly the T chapter, some in the S. And the reason why this is good is because before, in ICD-9, we just had those 800 and 900 codes that were very non-specific. We had to group a lot of post-op complications together. And this is so new that there were quite a few post-op complications, adverse events, poisonings on the ICD-10 test because this specificity is pretty new. Manifestation codes, there are many more combo codes. You still have to do manifestation and etiology. Don't get me wrong, there are those with that. But, like for instance, E11.40, you'll find out real fast that E11 is type 2 diabetes. 0.40 means it's type 2 diabetes with diabetic neuropathy, unspecified. Now, in ICD-9, we say 250, I should have put peripheral neuropathy. 25060 is diabetic with neuro manifestation, which means it's going to be that etiology and manifestation code followed by 357.2, polyneuropathy in diabetes. So you can see right there, it's easier. That also tells you why there are so many codes. There are a lot of combination codes. AHD, CAD, if you will, of the native coronary artery with unstable angina. So that's one that probably will be used a lot. But this is an example of you have to really read the code because that I-25.1 and then this one's 10, but there are many others because they don't have angina, they have this, they have that. Today, you code that as 414.00 CAD and then a separate code for angina. And so those combo codes will be nice, however, you have to read them carefully. Poisonings and external causes, T is mostly where this is, and you'll have, for example, remember that 7th digit is a D. That's subsequent encounter, that's home care. So you will know as you're putting in codes, you will never want to put an A. And in fact, most of the A's that you put in will be RTP'd, and you'll have to change them. So when you look at T36.0X1D, we know that X is what? Just a dummy placeholder. And we know that D is subsequent. The rest is poisoning by penicillin and accidental. And there's a nice chart on poisoning's adverse effects that you can use that is really helpful. Not as a handout, I'm talking about in the ICD-10 book. And so if you were coding this in ICD-9, you would have, whatever code it is, you would have the poisoning, the effect, and the E code for accidental. So you can see those three go into one. E codes have been replaced with T, W, X, and Y codes. They're all external events that occur instead of just E. Fractures is one of the biggest changes. How much have we had to drum it into everyone's head that we never code a fracture in home care? Guess what? We code fractures in home care. We don't code them anymore in 1024. What we will have is M1025, which is only optional. You do not have to code anything in 1025. It may be used for risk adjustment. It probably isn't, and it doesn't pay. But anyhow, fractures, we don't even have to worry about 1025 because now they go into our primary diagnosis or our secondary diagnosis. And think about it, why? Well, that 7th digit is saying that it is the subsequent encounter. Now, there are a lot more with fractures that I'll show you a chart. There's the malunions, the non-unions, the delayed healing, and so there's more than the D that's being changed here. The D would be our standard that it's routine healing in home care. Laterality. Non-specific codes are fewer in number, but they still have them there if you don't have the specifics in most cases. There are some cases that you have to. And code descriptions have changed a lot. Diabetes is no longer classified as controlled and uncontrolled. Here are the chapters, and because of time I won't go over them because I am giving you the handout that just shows you all of the chapters on a chart so you can see that easier. I talked about a lot of this, but as you look, and just keep in mind, next week pretty much the whole 90 minutes is about coding and coding rules and conventions and common coding. Or I shouldn't say next week, I'm sorry, I'm not sure when part 2 is, but when we do part 2, that's pretty much coding only. Okay, so, the days of an admission with dressing changes to the leg wound or a hospice physician. I have a hospice physician for a hospice client that we code for. There were also the consultants, so I talk to him all the time, but he repeatedly says end-stage heart. That's a very unspecific code. And dressing changes to leg wound, What type of wound is it, please? And what is the etiology behind it? Like I said, everybody's transitioning. So they're, physicians and hospitals and every other healthcare entity is hearing the same stuff probably at the same time. Don't forget about your intake staff. They need to know pretty much coding because a lot of times they have to put that preliminary ICD coding in, either into the software system or into the authorization for insurance. Also, a lot of systems, your field staff have to put something in. And you can't think that your field staff don't need to know much of this. They don't need to know the specific code numbers, but they need to know the rules. Medicare, this is billing and finance. Medicare expects a spike in rejected claims 3 to 6 months following ICD-10, peaking at 10% of claims submitted. And RTPs and denials of ATRs for incorrect codes and or lack of specificity, and they're giving us no grace period. And then don't forget, you're going to have denials and RTPs. So be sure your billing and collection staff are really up on handling these and that they are not delaying these. And you also know the MACs are going to have issues, and so that's going to be a problem as well. So make sure those incorrected claims that you're reading all the MAC email listservs and the emails that come out from them to see what they're fixing. And finance, you just need to have a plan to address potential cash flow issues from lowered productivity, denials, and incorrected submitted claims. Your QI department, they're doing QAPI, they're doing clinical records reviews, they're doing OASIS-C, maybe coding and clinical compliance. They have to have a good knowledge of ICD-10. If they don't, how can they be reviewing this? They won't know what the new rules are. Same with the field clinicians. A big thing is querying the physicians. If you're in-house with your own coder, as well as an outsourced company, they're going to be sending back more that they can't finish because the physician has to be queried for more information. Don't forget, diagnosis codes go on other things too, like lab requests, auth forms, DME orders. Your clinical documentation. Well, accurate coding depends on thorough documentation. I teach documentation and coding and continued survey readiness, et cetera, all the time. Before ICD-10, that was the main thing I was teaching. And it's still very secondary and will probably pop up again. The thing is that if your documentation is poor, it's probably going to get more poor with ICD-10 or for ICD-10. So you don't want to let up on in-services on clinical documentation. What is needed, what needs to be in compliance, because don't forget about sanctions. I mean, we have sanctions out there for condition level deficiencies too, so you can't take your eye off the ball when it comes to your clinical documentation. Just the, the last minute tips. Remember, there are not one-to-one crosswalks for all ICD 9 to 10 codes because there are so many more. I'm going to show you just in a second the crosswalk that I gave you, but it's just a guideline. In conclusion for today, ICD-10 is a big deal. It's a completely new code set, and it's not easy. You have to have a transition plan in place with an assigned leader. Make sure that it's very much like a plan of correction or action plan, that you're really checking off things that you have to do to be ready. Include your vendor tasks and have a detailed training plan. Have an emergency fund. Have backup plans for glitches. And I say October will be here before you know it, but gosh, we're doing dual coding now. So let me just real quickly show you the handouts. First of all, this is just the chapter list so that you can easily see Chapter 1, what it's about. Certain infectious and parasitic diseases is A00 to B99. So you'll see that Chapter 1 crosses over A to B, and neoplasms cross over C to D, and then D continues in blood forming, the leukemias, etc. So it's not even as simple as saying one alphabetical letter is for one thing, but then it is all the way down to the S and T. S&T for injury, poisoning, and certain other consequences of external causes is 2 huge chapters, S00 to T88. So this can help you just as a guideline to tack up in front of you to say, okay, here's where I have to go and what the numbers should be. The crosswalk is fairly large, and again, you'll see it is, a lot of them are one-to-one on here. This is a guide. Now, obviously, I tried to pick things that were pretty cross, but I'm talking in initials now from so much ICD-10. 153.9 is malignant neoplasm of the colon unspecified. So that does crosswalk to C18.9, malignant neoplasm of colon unspecified. Hopefully, from what you've been hearing from me, that is not what's desired. You want to look up probably C18 now, or crosswalk, the I1539, to get into that C chapter under C18 and see what other more specific types are there. So I have, a lot of examples here with the diabetes, with our common codes such as pernicious anemia, some of the others, the dementias, the cardiac, the Alzheimer's, etc. So then it goes on with, ulcers and wounds. I think that's it. No, I'm sorry, there's some weird page breaks in the way the chart went. So anyhow, you can certainly use that in training and as a guide, but be sure to tell people to definitely look it up, because there may be guidelines, there may be rules when to use it, and there may be 10 other codes. So that completes our part 1 of ICD-10, and you did see that I had to cram a lot of information into 90 minutes, and I hope that I didn't bore you or go over your heads, but thank you for joining me today, and we have a few minutes for questions. If Heather, do you want to open up for questions?
Yeah, that'd be great. Thanks so much, Sharon. Right now we're going to move into the question and answer section of today's call. I will unmute everyone's lines, so if you are not going to be speaking, if you could please make sure your lines are muted on your side so we don't have unnecessary feedback. Okay, all lines are unmuted right now. If anyone has any questions, feel free to ask.
I see that Deborah's asking, will we be getting a copy of our presentation handout? And you definitely will. So Heather will be sending those out to you. So you should have the PowerPoint, and then you'll be getting these 2 handouts. I think that's, Heather, can they get the handouts ahead of time for the next sessions?
Yeah, we can do that.
Okay.
Are there any additional questions?
I know that at the end of these classes, frequently there are not questions. However, I get a lot of people emailing me questions, and feel free to do that, because I know that this is so complicated and there is so much going on with it so quickly that you may want to email me your questions. So feel free.
Great. Well, if there's no other questions, I'd like to take this time to thank everyone for joining us during today's webinar. It's your participation and feedback on the post-webinar evaluation which allows VNAA to improve program offerings and activities. As a reminder, please have all quizzes and evaluations submitted by Wednesday, August 5th, 2015. I'd also like to thank our guest faculty, Sharon, for sharing her expertise, time, and commitment to making this a successful program. Thanks again for your participation. I hope you have a wonderful afternoon.
Thanks, everybody.